Hello friends, now we'll be discussing about bowel anastomosis, basics of bowel anastomosis. So, what are the principles of bowel anastomosis? So, before anastomosis, there should be good blood supply to the tissue, that is pulsatile flow after division of the terminal arterial branch, wherever we are transecting the bowel and planning to anastomose. There should be no hematoma, no collection of blood near the anastomosis, otherwise it will affect the hemostasis and wound healing. Do not jeopardize the mesentery by excessive clamping and ligating. So we have to protect the mesentery because it will give the further blood supply. We have to avoid tension while suturing and anastomosis at the suture line. Then avoid tissue trauma. So we should be gentle in our handling to the tissue. Then only bowel of similar diameter should be brought together in an end-to-end anastomosis. So we have to see that the diameter of the bowel is similar. So we have to try. If due to any reason it is not similar, then it has to be changed. So if there is minor discrepancy, we can do a chittle slit, which is along the anti-mesenteric border, opposite border, and then we can anastomose end to end. If there is major discrepancy, like it is not able to anastomose with chittle slit, or it will be too large, then we have to go for side to side anastomosis or even end to side anastomosis. So equal or equivalent luminal tissue should be anastomosed as end to end. Then accurate seromuscular apposition. So there should be no extraneous intervening tissue. So extra tissue should not be between the anastomosis. Then submucosa must be included in the suture. While applying the seromuscular stitches, Lamberts, because the submucosa has the maximum number of collagen tissue, collagen protein, which is having the most tensile strength of the whole layers of the GIT. So it should include submucosa, which is maximum strength. Then the suture material, ideally it is PDS. So here we have to consider that ideal suture material for intestinal anastomosis is one that has minimal or little amount of tissue reaction while provides maximum strength during the lag or the inflammatory phase, that is day 1 to day 5. Then inflammatory phase is fastened by necrosis, debris and infection. So we have to prevent all these things, debris, infection, and PDS has lowest adherence to bacteria, so less chances of infection. And braided suture like Vicryl will have higher chance of bacterial adherence up to 5 to 8 times. So earlier there was catgut was used in bowel anastomosis for the inside and silk for the outside. Later it was changed to Vicryl, and nowadays it is generally recommended that PDS is used. Then the technique, single layer versus double layer or continuous versus interrupted. So we have to consider that the tissue should be inverted and not everted while the anastomosis is concerned, and single layer is also good enough, especially in the experienced hands. Otherwise double layer is good, and continuous or interrupted both can be used, and it is a matter of preference and time aspect. Then some stitches. So corneal suture, so these are generally for the corners. These are full thickness, usually continuous suture, and these cause mucosal inversion and serves as the inner layer of the two layer anastomosis, and the technique is inside out and outside in, where the knot will stay inside the lumen, and after every suture there will be 2 to 3 mm of advancement. Then we have Cushing suture, which is similar to Cornell, but here we do not take the mucosa. So the tissue is exiting, the suture is exiting through the submucosa. Rest is similar to Cornell. Then we have Gambi, where we take interrupted suture that inverts the mucosa into the lumen. It is tied extraluminally and here used by some surgeon for pyloroplasty, stomach surgeries. So here we can see that it is going through full thickness, then including the mucosa and submucosa, then again going to mucosa, submucosa and including full thickness. Then the Lambert suture, which is commonly used for the seromuscular suturing in the second layer of the two-layer anastomosis. So it is started 3 to 4 centimeter lateral to the ends of the bowel, and it is only taken seromuscular as we have discussed, generally done in interrupted or also can be done in continuous fashion, and is used as the outer layer of the two-layer anastomosis. Then the Halsted, where we have horizontal mattress like seromuscular position, and here we have interrupted suturing. It is used for when the tissue is very friable and Lambert suture cuts through. So it is horizontal mattress with seromuscular apposition. Then the double layer bowel anastomosis, that is the Zerny-Lambert suture, where the inner full thickness layer is taken continuous with the absorbable, could be catgut, vicryl or even PDS, which is better. Outer is seromuscular, which is done with continuous or interrupted, usually permanent through the silk or PDS. Then we go for factors influencing healing of the intestinal anastomosis. So what are these influencing factors? Like the surgical factors, that is the integrity of the repair, surgical technique, secured knots, then tension in the repair, vascularity of the bowel ends as we have seen, proper mucosal inversion, luminal equivalence, and accuracy in the seromuscular apposition. So these are some 5 to 6 points which are considered in the surgical factors. Then the tissue factors, that is edema in the tissue. Higher the edema, difficult will be the anastomosis. Vascularity, if it is affected, then it will go to necrosis. Infection, inflammation, and malignancy, which will affect the wound healing. Then local infection, distal obstruction. If it is obstructed, then the tissue may not allow the passage of content, causing further distension and affecting the anastomosis. Irradiation due to any radiotherapy, etc., and some luminal content if it is irritant. Then the patient factors, that is the immune status, nutritional status, systemic condition like sepsis and shock, anemia, uremia, diabetes, and steroids. So what are the various phases of wound healing? That is inflammatory from 1 to day 3 to 5, proliferative in 1 to 3 weeks, and remodeling from 3 weeks to 3 months around. Then various configuration for the bowel anastomosis which we use is the end-to-end, which is preferred when the luminal caliber match similar equivalent lumens. It is most physiological, but there are chances of stricture formation if it is not in the experienced hand. End to side, that is done in the bypass procedure and can be done. One end of the loop is anastomosed to the defect of same size created in the antimesenteric border. So we have to consider that the other loop antimesenteric border is opened and the end of the loop is anastomosed there. So ileocolic anastomosis after right hemicolectomy. Then side to side, these are preferred when there is gross luminal discrepancy, or if there is if we are considering if there is stump involvement, then there is high chance of intraluminal bacteria and proliferation of the luminal pressure, proliferation of the bacteria and increased luminal pressure, and will result in blowout. So side to side is preferred when there is cross luminal discrepancy and if there is involvement of a stump and chances of increased intraluminal bacteria and proliferation and causing intraluminal pressure increase, causing blowout. So in these conditions, we should consider side to side anastomosis because that will have larger caliber and less chances of blowout. So this was all about principles of bowel anastomosis. Hope it has been understood in simply. And I would like to thank Chandana Shri ma'am for sharing these wonderful notes with us, which are very helpful for revision. And the link for the notes is given in the description below. You can download it from there. And thank you for watching. Please like, share, and subscribe. Keep studying, keep growing. Never give up because great things take time. And see you soon in the next video. Thank you.